Welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of today's conference. At that time, you may press star one on your phone to ask a question. I would like to inform all parties that today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the conference over to Ms. Helen Talley-McRae. Ms. Ray, thank you. You may begin.
Thank you, Sylvia. Good afternoon, everyone. My name is Helen Talley-McRae, and I work in the One Health office of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of the One Health office, I'm pleased to welcome you to the monthly Zoonoses and One Health updates call on May 1st, 2019. I'll just note that we are experiencing connectivity issues with Adobe Connect and with our Wi-Fi. And computer connection. So if you are disconnected, please try and reconnect again. If we are disconnected, we'll still have the phone line, so we'll try and keep the call moving along. ZOHU Call content is directed to epidemiologists, laboratorians, scientists, physicians, nurses, veterinarians, animal health officials, and other public health professionals at the federal, state, and local levels. Please be aware that CDC has no control over who participates on this conference call. Therefore, please exercise discretion on sensitive content and material, as confidentiality during these calls cannot be guaranteed. Today's call is being recorded, so if you have any objections, you may disconnect. Detailed instructions for obtaining continuing education are available on our website and will be given at the end of this call. These presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. The Planning Committee reviewed content to ensure there's no bias. CDC did not accept commercial support for this activity. CDC, our planners, presenters, and their spouses or partners disclose they have no financial interest or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Before we begin today's presentation, Dr. Casey Barton-Baravish, Director of CDC's One Health Office, will share some news and updates.
Hello, everyone. Thanks for joining us for today's ZOHU Call, and welcome to all of our new participants. We appreciate you helping us continue to spread the word about the ZOHU Call and letting your colleagues know that we offer free CE for live calls and web on-demand recordings, which are available on our ZOHU Call website. The ZOHU Call audience now has almost 14,000 subscribers, representing professionals from government, non-governmental organizations, industry, and academia, as well as students. Please continue sharing links to the ZOHU Call website, which includes information on free continuing education for a variety of professions, and a link to subscribe to the ZOHU Call email list. To begin today's call, I'd like to share highlights from the latest One Health news and resources. These links and others are included in today's ZOHU Call email reminder. Some new resources to highlight include that the U.S. One Health Zoonotic Disease Prioritization Workshop final report was just released on CDC's website. This report describes the collaborative process between CDC, the Department of Interior, and USDA, as well as other partners who work together to identify 8 priority zoonotic diseases for One Health collaboration in the United States. And this report also gives recommendations for next steps on advancing One Health in our country. You can also find links to updated content about horses and ferrets on CDC's Healthy Pets, Healthy People website. USDA APHIS has developed 3 new resources related to African swine fever. You can check out a new webpage on what CDC does about novel flu outbreak investigations. And also, EIS applications are currently being accepted for the 2020 EIS class until May 22nd. So please spread the word to physicians, vets, nurses, scientists, and other qualified professionals. Some upcoming events of interest include National Pet Week, which is next week, and we'll have a presentation about pets shortly on today's call that will include information on how you can participate in Pet Week. There's also a COCA Call webinar on May 7th that will discuss travel-associated rickettsiosis guidance with pre-travel counseling, diagnosis, treatment, and reporting. Some upcoming conferences include the Council of State and Territorial Epidemiologists in Raleigh from June 2nd through 4th, and the Association of Public Health Laboratories, which is in St. Louis from June 3rd through 6th. We've also shared some recent publications, including national surveillance data show an increase in spotted fever rickettsiosis in the United States, and an MMWR, a preliminary incidence and trends of infections with pathogens transmitted commonly through food through the Foodborne Diseases Active Surveillance Network, which is the subject of our first presentation coming up shortly. There are several new outbreak notices which have been released, including a multi-state outbreak of Shiga toxin-producing E. coli 0103 infections, salmonella infections linked to frozen raw tuna, and listeria infections linked to deli sliced meats and cheeses. As always, a selected list of ongoing and past U.S. outbreaks of zoonotic diseases, as well as information on staying safe and healthy around animals, is available on CDC's Healthy Pets, Healthy People website. The complete CDC current outbreak list is also available on CDC's homepage. If you would like for us to share news from your organization, or if you want to suggest presentation topics, or even volunteer to present, please contact us at zohucall@cdc.gov. As always, thanks for your support of the ZOHU Call and for joining us today. I'll now turn the call back over to Helen.
Thank you, Dr. Barton-Barabesh. Today's presentations will address one or more of the following objectives. Describe two key points from each presentation. Describe how a multi-sectoral One Health approach can be applied to the presentation topic. Identify an implication for animal and human health. Identify a One Health approach strategy for prevention, detection, or response to public health threats. Identify two new resources for CDC partners. Questions for all presenters will be taken at the end of the call. Call 1-800-593-8936 and enter participant passcode 9611836. Press star 1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of each question. You'll find resources and links for all presentations on our website and in today's ZOHU Call reminder email. Our first presentation, Foodborne Diseases Active Surveillance Network, FoodNet, preliminary data for 2018 will be given by Dr. Danielle Tack. Please begin when you're ready.
Hi, thank you, Helen. And hi, everyone. My name is Danielle Tack, and I'm a veterinary medical officer and epidemiologist with the FoodNet program. Today, I'm going to be providing an update on this year's report, which was released last week, that describes the 2018 incidence and changes in incidence of infection with pathogens transmitted commonly through food. Next slide, please. FoodNet is a collaboration with CDC, the 10 state health departments shown on the map in dark green, USDA, FSIS, and FDA, and we cover 15% of the U.S. population. FoodNet tracks important foodborne illnesses and generates information that provides a foundation for food safety policy and prevention efforts. We do this by conducting population-based active surveillance for 8 pathogens commonly transmitted through food: Campylobacter, Cyclospora, Listeria, Salmonella, Shiga toxin-producing E. coli, or STEC, Shigella, Vibrio, and Yersinia. We also conduct surveillance for pediatric hemolytic uremic syndrome. On slide 3, I'd like to review FoodNet's 4 objectives, which are to determine the burden of foodborne illness, monitor trends in burden over time, attribute burden to specific foods or settings, and disseminate information to improve public health practice and guide development of interventions to reduce the burden. On slide 4, we conduct active surveillance for laboratory-confirmed infections through a network of approximately 650 laboratories. We have collected data on confirmed infections since 1996 and on culture-independent diagnostic tests, or CIDT positive infections, since 2012. For CIDT positive infections, we collect test type and brand, the location of where the test was performed, We also supplement this case data with surveys of the clinical laboratories in FoodNet catchment to assess changes in diagnostic testing practices over time. We have conducted these surveys since 2012. Next, please. Before we jump into the report, I'd like to first provide some background on the changing diagnostic landscape and shift from culture to culture-independent diagnostic tests, or CIDTs. Culture is the traditional method for diagnosing enteric diseases, where the organism causing illness is isolated and thus available for additional testing. This additional testing includes determining antimicrobial resistance and subtyping, such as by whole genome sequencing, which is needed to link cases to an outbreak. Routine stool cultures performed in clinical labs typically include methods that identify only 4 pathogens: Salmonella, Campylobacter, Shigella, and STEC 0157. CIDTs detect antigen or DNA. These tests are faster than culture because they do not require isolation of the organism. This also means that antimicrobial resistance and subtyping information cannot be obtained. However, a reflex culture can be done after a positive CIDT result to obtain an isolate for antimicrobial resistance and subtyping information to be gathered. There are many types of CIDTs with varying sensitivity and specificity, meaning the ability to accurately give a positive or negative result. Use of syndromic panels, which test for many organisms simultaneously, began in FoodNet sites in 2015 and are becoming more common. An example is BioFire, which can identify 22 enteric pathogens in an hour, including those not typically included in a routine stool culture. Our annual clinical laboratory surveys and case surveillance data indicate that CIDTs are becoming more and more common, especially the syndromic panel CIDTs. Next. The MMWR report includes both culture-confirmed and not culture-confirmed cases, which are referred to as CIDT-only cases. Culture-confirmed cases include culture-positive only cases and cases with both a CIDT and a culture-positive. Cases not culture-confirmed include CIDT-positive and culture-negative cases, as well as CIDT-positive cases without culture done. An additional term that will be used in the presentation is reflex culture, which is culturing of a specimen with a positive CIDT result. A positive reflex culture means the culture yielded the pathogen. The MMWR includes the number and incidence of infections. The change in incidence was calculated using a negative binomial regression model comparing 2018 with the previous 3 years. The table on slide 7, going from left to right, shows the number of all cases, cases diagnosed by CIDT only, hospitalizations, and deaths for each pathogen. Next. Looking at the bottom row, in total, there were almost 26,000 cases, 30% of which are CIDT only. For bacterial pathogens, this means about 70% of cases diagnosed were culture confirmed. There were almost 6,000 hospitalizations and 120 deaths. Next. Campylobacter and Salmonella had the highest number of cases reported, accounting for approximately 73% of infections. Next, Yersinia had the highest proportion of CIDT-only cases, with 50% not culture confirmed. Next, as expected, Listeria had the largest percentage of cases resulting in hospitalization and death. On slide 8, we have a closer look at the number of cases reported since 2015 by culture status. Each graph shows a different pathogen with the number of cases on the y-axis and the year on the x-axis. In the solid purple bars at the bottom is the number that were culture positive only. Next, in the solid teal bars are cases that had a positive CIDT test and a positive culture. The striped bars show the infections that were CIDT positive but culture negative. Finally, the dotted bars at the top illustrate the number of infections that were CIDT positive and not tested by culture. Note that there are different testing practices for each pathogen. For example, CIDTs represented by the teal sections have not been widely adopted for Listeria, the top center graph. In contrast, STEC, located at the bottom row, second from the left, is all teal. This is because a positive CIDT for Shigatoxin is required for an STEC diagnosis. Focusing on the teal-colored sections, cases initially diagnosed by a CIDT has been increasing for most pathogens. The number of cases diagnosed using a CIDT increased by 65% in 2018 compared with 2015 to 17. This ranged from 29% for STEC to 311% for Vibrio. On slide 9, the first graph shows an increase in the percentage of cases diagnosed by CIDT by pathogen. The percentage of cases diagnosed by CIDT is shown on the y-axis and the year on the x-axis. STEC, the solid orange line, is relatively stable at the top. As I mentioned before, to be classified as an STEC case, detection of Shiga toxin by CIDT is required. Listeria, the gray dashed line at the bottom, is mostly culture. The percent change in the number of cases reflex cultured parallels the overall increase in CIDT. The middle graph shows changes in the percentage of CIDTs with reflex culture, which reflects changes in reflex culture practices versus increases in CIDT use. For most pathogens, reflex culture is increasing. The largest increase is seen in Shigella, the purple dashed line, while STEC, the solid orange line, is decreasing. The last graph on the right depicts the percentage of reflex cultures that yielded the pathogen. At the top, Listeria, the dashed gray line, and Salmonella, the dashed brown line, have the best recovery rates. Campylobacter in solid blue appears to be improving. If you compare across graphs, Listeria, the gray dashed line, and Salmonella, the brown dashed line, have the highest percentage of culture confirmation. Therefore, we anticipate good rates of isolate recovery if CIDT use were to increase for these pathogens. Next. This table shows the 2018 crude incidence rate and the percentage change in the incidence in 2018 compared with 2015 to 17 average annual incidence. We did not assess change compared with 2006 to 2008 due to large changes in testing practices over the time period. The significant changes are indicated in bold. Next. We see that Campylobacter increased 12%, Salmonella 9%, Shiga toxin producing E. coli, 26%, Yersinia, 109%, Vibrio, 58%, and Cyclospora, 399%. Next slide. Because CIDTs do not provide serotype information, we have to look at changes in serotype among only confirmed Salmonella infections. Among the 8,090 confirmed Salmonella infections, 713, or 87%, were serotyped. Since 2013, the most common Salmonella serotype reported was Enteritidis. We did not observe a significant change in incidence compared with 2015 to 17. The second most common was Newport, and third was Typhimurium. Like Enteritidis, we did not observe significant changes in incidence for these serotypes. Next, please. There were 1,570 confirmed STEC infections reported in 2018. 440 were STEC 0157, and we did not observe a significant change in incidence compared with 2015 to 17. There were 1,130 STEC non-0157 infections. Similarly, we did not observe a significant change in incidence compared with 2015 to 17. There were 54 cases in post-diarrheal HUS in children aged less than 18 years during 2017, which is the most recent year for which data are available. 36 or 67% of these cases were in children aged less than 5 years. We observed no significant change in incidence of HUS in either age group compared with the preceding 3 years. Next. Again, there were 1,130 STEC non-0157 infections reported during 2018. Among these, 662, or 59%, were serogroups. 2018 is the first year 0103 was the most commonly isolated non-0157 STEC at 31% of all non-0157 STEC with serogroup information available, followed by 026 and 0111. These three serogroups account for 80% of serogroup STEC non-0157 isolates. Next, please. The key points discussed in this year's report are shown here. First, Campylobacter is the most commonly reported pathogen, accounting for 38% of all cases reported to FoodNet. Second, Salmonella serotype Enteritidis is the most common serotype reported, accounting for 19% of all serotype Salmonella, and incidence remains unchanged. Third, contamination of produce is an important source of infections, which was reflected in the multi-state outbreaks of Cyclospora and STEC 0157 that occurred during 2018. Furthermore, Cyclospora has been previously associated with produce. The 399% increase in incidence was likely due to several factors, including these outbreaks and continued adoption of CIDTs. This provides an opportunity to better understand the role of produce as a source of infection. The last point is some encouraging news. Although CIDT use has increased with 65%, reflex culture was attempted on 75% of specimens and 71% yielded the pathogen. Culture provides critical information to detect outbreaks, inform treatment, and target control measures. Therefore, culture is encouraged following a CIDT positive result. Next. As in the past years, additional materials related to this report are available online, including questions and answers, as well as data. The 2018 changes in incidence tables are available online as well. We also provide data through FoodNet Fast, which offers customizable, downloadable searches of data on cases reported to FoodNet since 1996. Thank you all. I'll now pass the line back over to Helen.
Great. Thank you so much, Dr. Tack. Our next presentation, Healthy Pets, Healthy People, using a One Health approach to prevent pet zoonoses, will be given by Dr. Kate Varela. Please begin when you're ready.
Thank you, Helen, and thank you to everyone for the opportunity to talk to you today. I'm a veterinarian and have worked in both clinical practice with small animals and public health, working at the human-animal environment interface to prevent zoonotic diseases as well as on other One Health issues. I've been with CDC's One Health office for almost 2 years now, and I'm very excited to share a bit on how we're using a One Health approach to prevent pet zoonoses. So we wanted to highlight pets on the ZOHU Call this month to celebrate National Pet Week, which is actually next week, May 5th through 11th. Pets, whether covered in fur, feathers, or scales, can bring joy, amusement, and companionship to our lives. But with these many benefits, sometimes they can carry germs that make us sick, even when they look healthy. So it is important for everyone, whether you're a pet owner, veterinarian, healthcare provider, or other, to know what the risks are and how to stay healthy while enjoying your pets. So I'm going to share some of the activities at CDC that are aimed to prevent pet zoonoses, including resources to help encourage practicing healthy habits around pets. And I want to start by emphasizing that the health of humans is connected to that of animals and our environment. Pets and other animals offer many benefits to our lives, including reduced stress, improved mood, companionship, and increased opportunities for exercise. And the importance of pets is evidenced by the numbers. According to the 2017 to 2018 American Veterinary Medical Association Pet Ownership and Demographics Sourcebook, 57% of all households in the United States owned one or more pets in 2016. This was over 74 million households in the United States. So you can see by the chart on the left that traditional pets like dogs and cats are still the most popular pets. And dogs seem to be the family favorite, with 38% of households owning at least one dog at the end of 2016, which is actually the highest estimated rate of dog ownership since the AVMA started measuring this in 1982. And it's actually 10% higher than the last survey, which was conducted in 2011. However, we're also seeing an increase in the popularity of non-traditional pets. So 14% of households surveyed owned non-traditional pets in 2016, which was actually a 25% increase since 2011. And non-traditional pets include reptiles, amphibians, small mammals like ferrets, rabbits, hamsters, and other pets like fish and backyard poultry. And actually, one other notable figure is the number of backyard poultry that are being kept as pets. There were 1.4 million U.S. households that owned backyard poultry in 2016, and this is an estimated population of 15 million chicks, chickens, ducks, and other poultry. According to the American Pet Products Association, these non-traditional pets are increasing at an annual rate of 4%, and that trend is expected to continue. And as the number of pets has increased, the amount of money spent on them has also steadily increased, with over $66 billion spent in 2016 on animals and associated items like food, other supplies, and veterinary care. And we also know that zoonotic outbreaks are more commonly being detected. Zoonotic diseases, which are those spread between people and animals, represent the majority of infectious diseases that exist today, and they're continuing to emerge. Within the last 10 years, we've seen outbreaks linked to pets, including the species shown here, such as tiny turtles, petting zoo animals, frozen and live rodents that are used to feed reptiles, a variety of small mammals, backyard poultry, aquatic frogs, pet store puppies, and even pet food. And many times these outbreaks occur because people don't realize that pets can appear healthy and clean, not showing any signs of illness, but still be carrying and even shedding the pathogens that make people sick. So since non-traditional pets are becoming increasingly popular and have been linked with outbreaks of zoonotic diseases in people, we wanted to characterize the number of outbreaks and types of pathogens associated with these species in the United States. To do this, we conducted a comprehensive literature review for outbreaks and case reports between 1996 and early 2018 related to contact with non-traditional pets such as reptiles, amphibians, small mammals, and backyard poultry, which are technically livestock but are increasingly being treated like pets. There were about 1,400 articles that were screened and 141 which were reviewed in detail. And in addition, we received data from CDC's National Outbreak Reporting System, which is a web-based platform used by local, state, and territorial health departments to report enteric outbreaks transmitted by contact with animals. The preliminary results of our review included 240 outbreaks or case reports of human illnesses between 1996 and 2018 that were associated with contact with non-traditional pets. This included over 9,000 human illnesses, and 15% of these illnesses were in children under 5. There were 4 pathogens identified that accounted for the majority of cases, including Salmonella, lymphocytic choriomeningitis virus, or LCMV, Streptobacillus moniliformis, which is also known as rat bite fever, and sole virus. And when we broke it out by pet type, the results of our review showed that the predominant pathogen for reptiles and amphibian-related outbreaks was Salmonella, with almost 3,000 illnesses reported in 72 outbreaks or case reports. The same was true for backyard poultry and Salmonella, with over 6,000 human illnesses and 115 outbreaks or case reports identified. Small mammals were linked with multiple zoonotic diseases, including LCMV, rat bite fever, and sole virus. However, Salmonella was again the predominant zoonosis linked to small mammals with 391 human illnesses. And of note, whether live or frozen, feeder rodents were responsible for both Salmonella and LCMV illnesses. So to address these zoonotic disease challenges, a One Health approach is critical. The U.S. government has a definition of One Health, which is shown here. One Health is a collaborative effort of multiple disciplines and sectors coming together with the goal of achieving optimal health outcomes while recognizing the interconnection between people, animals, plants, and our shared environment. And One Health applies at the local, national, regional, and global levels. We really feel that using a One Health approach is the best way forward to address and prevent pet zoonoses and other zoonotic diseases. So we're using a One Health approach by partnering with many different groups across human, animal, and environmental health sectors. We do this to reach the most people, to inform zoonoses prevention messaging, and to update stakeholders with evidence-based information. And we distribute this messaging through a variety of ways, including the ZOHU Call here, like today, our Healthy Pets, Healthy People website, and many avenues of social media and networking. So we engage partners strategically to maximize CDC's impact on zoonoses prevention. Here I've listed just a few examples, including our work with the National Association of State Public Health Veterinarians on a variety of different guidance documents for veterinarians and other stakeholders, including compendium documents on preventing disease transmission with animals in public settings, like petting zoos, farms, fairs, schools, and other places that people may encounter all kinds of animals. And currently, we're actually working on a similar compendium that is specific to non-traditional pet species. These are great resources not only for veterinarians, but also for physicians and other human healthcare providers, those in the animal industry like breeders, retailers, and distributors of pets, as well as pet owners and anyone else really who interacts with animals. Another important partnership that we've cultivated is the Zoonoses Education Coalition. And this is a One Health partnership that brings together experts from government, academia, associations, industry, and others to exchange information to help inform evidence-based messaging and help increase public awareness on how to enjoy pets without getting sick. We're also engaged in public-private partnerships with the pet industry, including the Pet Industry Joint Advisory Council, which represents all segments of the pet industry from breeder to retailer. Through this partnership, we help educate pet industry stakeholders to promote evidence-based educational materials, as well as best management practices. And one example you can see on the right is the Zoonotic Disease Prevention Series for retailers that includes best management practices on diseases like Salmonella, LCMV, rat bite fever, and others, specifically for retailers of pets. And these partnerships are really useful to inform stakeholders broadly during an outbreak. Through them, we can potentially reach a wider audience than we would otherwise have, since they distribute health alerts to members and provide timely updates to their members. One of the major ways we distribute prevention messaging is on CDC's Healthy Pets, Healthy People website. And this is the only U.S. government website of its kind. It houses information not just about the health of people, but also animals, and its content continues to grow and evolve. In 2018, the site got over 800,000 hits with visitors from over 50 countries throughout the world. And we really want this website to be a sort of one-stop shop for pet owners and others who want to know how to stay safe around pets, farm animals, and wildlife. We keep it up to date with timely information on domestic outbreaks linked to animals and animal products, and there are a variety of educational materials to print or share electronically. There's also information for specific groups, like parents or animal exhibitors on the website, and I wanted to highlight that we recently added pages specifically for veterinarians and physicians or other human healthcare providers. These pages have guidelines and recommendations, disease-specific resources on common pathogens, zoonotic disease outbreak information, and CDC expert commentaries, as well as resources for clients and educational materials. So the website is a great resource for pet owners with questions about specific types of pets and the germs they might carry. You can see here are just a few examples of flyers that are all available to download for free. There are some with general info on healthy pet habits, and then there's some with more specific information on staying healthy with reptiles and amphibians, small mammals, and you can see on the flyer in the middle here, it has one of our favorite messages, which is to never snuggle or kiss your pet lizard or gecko or chicken. And then the flyer on the left is an example of how to properly check and remove ticks from pets. So I'd like to emphasize that since over half of all U.S. households have pets, whether you're a clinician for humans or animals listening in, these types of resources would be great to have in your waiting room or to refer patients or clients to as well. As I mentioned, the website also has up-to-date information on current zoonotic disease outbreaks and outbreaks from previous years. And you can sign up for the RSS feed and get updates as they become available if you're interested. So these are just some of the ways we're working to promote and protect pet health in the United States, because we truly believe that pets are an important part of our lives, and they will continue to be an important factor in shaping human health needs. And we really want to help people choose the right pet, promote responsible pet ownership, and educate on how to prevent diseases so that people can enjoy their pets without getting sick. This is because we like to say there is a right pet for everyone, but not all pets are right for all people. So if you'd like to hear more from us on this, please feel free to sign up for our newsletter or email us. This is our contact information. And thank you so much.
Okay, thank you so much, Dr. Varela. Our final presentation, Human Rabies, Virginia 2017, is by Dr. Julia Murphy. Please begin when you're ready.
Well, thanks very much. Can everybody hear me all right?
Yeah, that's great.
Okay. Well, thank you. I appreciate the opportunity to describe on behalf of the many people involved the investigation associated with the most recent human rabies case in Virginia, which was reported in 2017. This patient was a 65-year-old female with no significant past medical history who was retired, and she was a resident of a communal living facility in Virginia. On May 3rd of that year, she began experiencing pain and some paresthesia in her right arm and shoulder as well while gardening. And a few days later, on May 6th, she sought care at an urgent care facility for that arm pain. And there she received a diagnosis of carpal tunnel syndrome and was prescribed a non-steroidal anti-inflammatory drug and also some hydrocodone. But the following day, she started experiencing anxiety and insomnia and some difficulty swallowing water. And for that, she was evaluated at a hospital, Hospital A. And there, at that hospital, the patient was assessed as having a panic attack, and she received lorazepam, and she was discharged. Then on the day after that, though, her symptoms really started to become pretty severe. As you see, her shortness of breath, her anxiety became more intense. She started experiencing chest discomfort, and so on May 8th, she was transported from her residence by ambulance to the emergency department of Hospital B, where not only were these the clinical symptoms you see there on the first bullet described, but she also described having progressive paresthesia involving her right shoulder and arm. She was admitted to Hospital B, and later that day it was noted that she was becoming progressively agitated and combative. She was noted to be gasping for air when attempting to drink water, and at that time, at that juncture, Hospital B staff members started questioning the patient's family about animal exposures, and the patient's husband reported that she'd been bitten on the right hand by a puppy approximately 6 weeks before symptom onset while she was in India. According to her husband, the patient cleaned the wounds after the bite with the help of a tour operator, but she did not seek any further medical treatment. And it was also noted that the patient did not receive rabies pre-exposure vaccination before she went on this trip, nor had she ever been vaccinated against rabies. Now, after the patient's husband revealed that she'd been bitten while touring in India, additional details about that were obtained, and these revealed that this was a lengthy trip. It was of a little over 2 months that she was in India, and that she was one of 17 tour members from 5 states, namely California, Illinois, Maryland, North Carolina, and then also Virginia, of course, and 2 countries. 6 staff members from 2 countries also participated in this tour. Other tour members at this point did confirm that the patient was bitten by a puppy outside of her hotel in Rishikesh, India, and that the wound was washed with water, but no further treatment was administered at that time. Now, shortly after this exposure history was revealed, and also in consultation with the health department, our Hospital B obtained and shipped antemortem samples for rabies to the CDC Rabies program, and on the 11th, rabies was confirmed with sequencing of the virus identified as a canine rabies virus variant associated with dogs in India. At that time, the Milwaukee protocol was implemented and used as a guide for her care and treatment. Repeat cerebrospinal fluid analysis on May 18th demonstrated no evidence of anti-rabies virus antibodies, but rabies virus nucleic acid was again detected in saliva by PCR on May 19th. And on May 21st, the patient's family decided to withdraw support. Brain tissue from this patient was then submitted post-mortem to the CDC Rabies program, where the rabies virus was isolated. So now the public health aspect of this investigation really began on May 9th, and groups were identified that would need to be assessed for exposure. The healthcare provider groups identified, you see listed there, were all located in one health district, and while the communal living facility where this patient resided is located in a neighboring health district. So we have two Virginia health districts involved in the follow-up. And the patient's communicability period was presumed to have been 2 weeks before symptom onset, so that was April 19th forward is where we were looking for possible communicability. The recommendation to Hospital B staff on May 9th was to follow standard infection prevention precautions while caring for the patient. And due to concerns that other tour group members may have been exposed to the same puppy that bit this patient, the CDC Rabies, the CDC Rabies program then took the lead on contacting the travel company to coordinate outreach to those who participated in the same tour. The health district local to the healthcare centers where the patient sought care used an existing survey tool that was developed in response to a previous human case we had had in order to assess exposure risk, and they just used that tool and modified it for this purpose in order to try to assess exposures in as standardized a way possible. and in order to make recommendations for post-exposure prophylaxis. And in addition, in-person outreach and discussions with members of the patient's communal living facility were initiated by the health district local to that facility. And in coordination with the communal living facility, that health district held a town hall style meeting on May 12th, and local public health personnel began performing exposure assessments that same day. The healthcare worker survey that was used focused on capturing job duties of anyone who assisted in this patient's care, and also the personal protective equipment used when performing those duties relative to any infectious materials like saliva, respiratory secretions that could have contained saliva, and also central nervous system tissue. The community member interviews and outreach focused on those who had had direct contact with the patient and specific interaction with the patient, particularly ones that increased the likelihood of direct contact with the patient's saliva. A total of 258 healthcare workers were identified for assessment, and of those, 250 were located and assessed. Further, of those, 72 were recommended for prophylaxis. We found that the rate of post-exposure prophylaxis recommendations per day decreased significantly after the diagnosis of rabies was made, and that in part is what the next slide I'm about to show you illustrates. This figure depicts the number of rabies post-exposure prophylaxis recommendations made from May 6th through May 23rd. Now, during May 8th through May 10th, which was before the confirmed rabies diagnosis, staff members at Hospital B had been recommended to follow standard infection prevention precautions, which is the typical recommendation for those caring for patients suspected of having or confirmed with rabies. And you'll see, though, that at one point in the patient's hospital stay, additional personal protective precautions were implemented. These additional precautions were implemented after the patient developed an antibiotic-resistant urinary tract infection, and this development presented us with a unique opportunity to assess the impact of these enhanced precautions on the number of reported exposures. As the graph illustrates, the number of healthcare workers recommended for PEP decreased significantly after the diagnosis of rabies was made on May 11th, falling from a rate of approximately 15 per day because of likely exposure to the patient's saliva to about 2 exposures per day after that diagnosis was made. In addition, the daily rate of post-exposure prophylaxis recommendations did not differ significantly between May 11th and the window of time between May 18th and May 21st, which is when these enhanced precautions were implemented. This tends to support the ACIP recommendation that standard precautions are adequate to minimize healthcare-associated rabies virus exposures. Local health department staff interviewed 13 members of the patient's communal living facility who identified themselves as having had contact with the patient during the infectious period. 4 of these 13 met the health department's definition of exposure to rabies via contact with the patient's saliva, and all 4 of these patients were recommended to receive PEP. The CDC identified the remaining tour group members and staff for follow-up. Of these, 3 tour group members, in addition to the patient, reported direct contact with the same puppy. 2 were determined not to have been exposed to infectious materials based on their recounting of their interaction with the puppy, but 1, a North Carolina resident, was recommended to receive rabies post-exposure prophylaxis after she reported having been bitten on the leg by this same puppy. So I would just offer the following comments by way of closing, which include that early consideration of rabies infection coupled with timely diagnosis is important, and that this report offered us a unique opportunity to assess standard precautions as a recommendation, which tended to be supported by our analysis. And also that pre-travel preparations, including rabies pre-exposure prophylaxis, are important considerations, particularly if a person is traveling to a remote area where canine rabies is endemic. And here are some highlighted resources, including the full MMWR, which gives more detail about this investigation. And actually now, almost as long, I have to say, as the presentation itself, I've listed on the following slides all the people who played a critical role in helping with this investigation, who I'd like to acknowledge. And I'm hopeful that some of these folks are on the line and might be able to participate in any discussion. And again, I appreciate everybody's time and the opportunity to present this case.
Great. Great. Thank you so much, Dr. Murphy. At this time, we'd like to take questions for any of our presenters. Call 1-800-593-8936. I'll put the number up in just a moment here. Sorry. It's again, call 1-800-593-8936 and enter participant passcode 9611836. Press *1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of the question. Sylvia, do we have any questions on the line yet? Sylvia, do we have any calls on the line yet?
Yes, ma'am, we do. We have one from a Kyle Enfield.
Great, okay.
Sorry, this is Kyle. I was actually just asked to call in since I'm from the University of Virginia in case there were any specific questions about the UVA response.
Okay, great. Okay. Just give it another minute and see if we have some questions on the line. Bear with me. I'm trying to get reconnected to the presentation.
We have one more question coming up from Karen Stevens.
Great.
Hi, this is Karen Stevens in Indiana. My question was for Julie Murphy. I was wondering what the nature of the exposure was for the 4 community members who were recommended to receive PEP.
Well, I don't know if Rhonda Pruitt is on the line. She was one of the folks who took the lead locally there to assess exposures, but mostly it was saliva contact, as far as more intimate contact, personal contact with the patient.
Thank you.
Debbie, this is Helen. If you could, I can't advance the slides. I'm not sure what's going on. Sylvia, do we have any other questions on the line?
Yes, we do. We have a question from Rhonda Pruitt.
Great. Go ahead.
Hello. Actually, I didn't have a question. I work with the health department that helped to perform the investigation on the human rabies case that Dr. Murphy presented. And I just wanted to follow up on the question that was received that she's responded to already about what criteria we use to evaluate contacts with the patients that resulted in us making PEP recommendations for them. The husband of the patient reported that when she was becoming quite agitated and combative, she actually bit him during that time. And the other 3 individuals who were very close friends and contacts of the patient had indicated that they had direct contact with her saliva during the time frame that CDC recommended that we look for that type of contact, which went back 14 days prior to the onset of her symptoms. So I hope that that does help answer that question.
Great, thanks. I'm sorry we're having network issues, so we're probably not seeing the right slides. We just have a slide up about the calling in for questions, but we're still working on that. Finish up. Do we have any other questions on the line, Sylvia?
No, not right now. We do not.
Okay, we'll just wait a few moments.
As a reminder, press *1 on your phone and record your name if you have a question.
Okay, I'm going to ask one more call for questions. Is there anyone on the line?
I have one. Yes, we do have one.
Okay, excellent.
One moment. There you go.
Hello?
Hi, who's calling, please?
Hi, my name is Judy.
And
I missed some of the part of this because I got called away, but with the rabies case, I was just curious when the history was done, like the woman's travel history.
I'm sorry, when it was taken?
Yeah, as far as in the status, like when she first presented, was a travel history done as part of like standard questioning?
Well, not when she very first presented. It was the travel history was collected when she presented to the second hospital. By that point, her symptoms and her clinical course, I think, was certainly concerning. And I don't, Dr. Enfield, who's on the line, I'm happy to have you speak to this, but her symptoms and clinical course were concerning for rabies, and that is when there was further investigation of her animal exposure and travel history. So that was around May 8th, which was about 5 days after she started manifesting clinical symptoms which associated with rabies.
I was just curious because it seems like if somebody's sick, I know if I traveled to India or something like that, of course I would probably volunteer like, hey, I was just somewhere. Could it be related to this unusual place that I was? But I just didn't know if collecting travel history anytime anybody presents with some kind of illness. No?
Well, to my knowledge, in this situation, the patient did not necessarily volunteer that information early on, and I don't believe that the other healthcare facilities necessarily inquired. I do know that we certainly, in many instances, encourage travel history to be collected, and it was in this case when the patient presented to the second hospital.
Okay, thank you.
Yes, ma'am.
Great, thanks, Dr. Murphy. Do we have any other questions on the line, Sylvia?
I I show no further questions at this time.
Okay. Well, great. I'll go ahead and wrap up the call then. We'd like to thank all of the presenters for their excellent presentations today. And thanks to everyone for listening. And again, apologies for our issues with the connection. The continuing education information is available on our website. All the instructions are there. If you go to cdc.gov/onehealth/ZOHU/continuing education, the course access code is OneHealth2019. To receive free CE for today's webcast, complete the evaluation at cdc.gov/TCE online by June 3rd, 2019. A web-on-demand recording of today's call will be posted by June 4th, 2019. Our next call will take place on Wednesday, June 5th at 2 p.m. Eastern Time. Please send suggestions and questions to zohucall@cdc.gov. For more information and to subscribe to our email newsletter, please visit cdc.gov/onehealth/ZOHU. Thanks again for your participation. This ends today's call.
That concludes today's conference. Thank you for participating. You may disconnect at this time. Speakers, allow a moment of silence and stand by for your post-conference. Thank you.